Tom?
Yep, that's perfect. Thank you.
Wonderful. Okay. So I'm going to present some recent data, but first, just a reminder of the programme. And as you'll recall, from April of this year, we've actually got kind of full coverage of the country. So Wave 4 sites have joined us, and I'm pleased to welcome some Wave 4 colleagues here on the Learning Day as well. So we've got full coverage, and you'll remember the priority groups: mental health patients, self-harm, middle-aged men, also COVID as a part of that. And what we've done now is we've done site visits with all the Wave 4 sites. So those of you in Wave 1 or 2 had the fortune or the misfortune to have kind of face-to-face visits from us back in the day. Obviously Wave 3 and Wave 4 have been virtual, but we've now completed all the site visits. But there's other bits of support you can get from us, and you can expect telephone clinics, virtual calls, and we'll also help you, of course, with your data. But the other thing I just wanted to say is we've had a bit of a refresh in terms of staffing as well. So Nicola Richards, who many of you have worked with closely, has gone off to pursue clinical training. So she's been, she can't be replaced, of course, but she's handed over her responsibilities to Andrea and Debbie, who will be in touch with all of you over the coming weeks and months. And I know we're on the call, so I might ask Tom to get them to introduce themselves, just perhaps in the discussion. Sugwan's been ably holding the fort in the interim, and Kathy's our project manager, Lewis, of course. So new staff members, a bit of a kind of refresh. And many of you have seen this slide before, but it's a reminder about, if you like, some of the early wins, some of the early outputs from this programme. So this is obviously results from our real-time surveillance, so suicide data in real time. But basically the 10 sites that supplied data as part of this study were 10 of the sites participating in the quality improvement programme. So not only is it us feeding information to you, it's you guys generating the information that then feeds up kind of nationally. And this was a really important message. You'll remember some of the stuff that was around about suicide rates are going to rise. There's going to be an epidemic of suicide deaths, and in fact what the real-time data that many of you helped generate showed was that there was no rise. And we first put that out in November last year, the fact that, based on the real-time surveillance, there hadn't been a rise. 10 months later, so last month, we actually had the official ONS data, so not from 10 areas here, from all areas in the country. And obviously that it's not a delay as such, it's the time it takes for coroners to hold inquests, for the data to be processed by the Office for National Statistics. But again, not showing any rise based on that official data, but a reminder that this was 10 months later. So you guys told us early on, we got an early signal, but then confirmed by the official data 10 months later. And in fact, in some groups, the trends showed quite a substantial fall. So this graph splits it by persons, males and females. But what I want you to look at here is the purple bar. So that is the suicide rate in males from April to July 2020, and these other bars are the suicide rates in the equivalent period in previous years. So actually, for men, the suicide rate fell quite significantly in the early part of the pandemic, and we saw a similar fall in younger people. So for some groups, the rates actually fell. Obviously, there's sometimes there's groups where suicide rates have risen, and in older women, so women over 75, there appeared to be actually an increase early on in the pandemic, but actually that wasn't statistically significant, but something we need to keep a close eye on. But in general, rates did not rise, and in some groups they fell very significantly. So that's the ONS data out last month. I'm always talking about how sometimes we have to see the suicide data in context. So, what's happening to self-harm. So these are data on self-harm, which comes to the attention of GPs primary care. Yep.
Yeah.
Is someone trying to say something? Otherwise, I'll just carry on.
Okay. I'm on the. How did you not get? I'm on the suicide learning with Raj.
Sorry, Nav. I think we just need to mute everyone, and then if you come off mute, then we can continue.
Okay. Right. Everyone hear me? Is that okay, Tom?
Sorry.
Yep. We okay? Great.
Yep.
Okay. So we can't see suicide data in isolation. We've got to see it in context. So this is self-harm. Primary care presentations for self-harm is data generated by my colleague Sarah Steig. And the big story there is this fall off in consultations for self-harm in primary care round about the time of the first lockdown. So that's most likely to be people not kind of consulting because they were wanting to protect the NHS or were kind of slightly fearful of entering health care settings. But this fall off in that first lockdown, but not the same for all groups. So just drawing your attention to 10 to 17-year-olds, it does seem to have been a fairly kind of steady increase since that first lockdown. So important, we need to keep an eye on self-harm going forward. Important to recognise the effect may not be the same in all age groups. And in fact, we've got some early data from emergency departments locally to suggest rates might have gone up over the summer quite significantly. So seeing the data in context. So sometimes it seems like the pandemic's gone on forever, doesn't it? But in fact, it's 18 months. And this paper that we contributed to has come out since we last met. It's really a reflection on what's gone on over the last year or more, and trying to kind of figure out this apparent paradox, because we know the pandemic has had impacts on people's mental health. That's been variable, but there's been generally a kind of negative impact, and yet suicide rates don't appear to have increased. So what's behind that? And this article makes the point that, well, some of these risk factors have increased, but so have some of these protective factors, this idea of social cohesion and togetherness at the time of crisis, but also some of the economic mitigation factors that have been put in place in this country and elsewhere, and also if you like, the closer kind of supervision that many people had, when everyone was at home during the lockdowns. There's this idea that people were less perhaps isolated in those periods, that may have mitigated some of the effects and meant that we didn't see an increase in suicide. But that's well worth a look at our paper. Okay, I've given you a bit of the kind of COVID related update, but as we move forward out of the pandemic, it's about some of the groups that were important for suicide prevention before the pandemic, they're important during the pandemic, and they're going to be important if we're thinking about preventing suicide in the recovery period. So I mentioned this report last time. We hadn't done our launch, but it's about suicide in men in midlife, the group with the highest suicide risk. Basically a detailed study of nearly 300 men in midlife, where we went to coroner's records and looked in detail at the antecedents. And this was probably the most striking finding. Often we talk about men in midlife, well, they don't seek help, they don't talk, do they? But in fact, in this study, we found that about 90% of men had contact with some kind of services prior to their death by suicide. So for nearly 80% was primary care, but also mental health services or the emergency department. For 2/3 that had been recent contact within 3 months, and about 1/3 of men in midlife who died by suicide have been contacted in the week prior to death. So this idea that men don't talk, men don't seek help, probably needs a bit of kind of adaptation, if you like. And really what we need to be thinking about is having services that are fit for purpose. So when men do present, how do we make sure that we've got interventions that suit their needs? Thinking about safe prescribing, the availability of talking treatments, and also the recognition of risk. So things about, you know, services being fit for purpose when men present services. Suicide amongst different ethnic groups is another issue we've been talking about in recent times, and again, this is recent data since we last met, coming from the Office of National Statistics, and they did an amazing thing where they basically linked death data to census data, because ethnicity isn't recorded on death certificates. So basically, they've done this clever linkage study where they can identify the ethnicity of people who've died by suicide, and what they've reported is that the suicide rate in most ethnic minority groups is actually lower than in the white population. The exception to that is people from mixed or multiple ethnic groups, and you know, we can think of reasons why that might be. So in general, the rates are lower, but in mixed or multiple ethnic groups, the rates are higher. Thinking about ethnicity in relation to self-harm, this is a paper that came out 2 or 3 weeks ago from a multi-centre study led by my colleague Bushra Farouk, and it looks at rates of self-harm in young people over time. And what you see is, you see this rise in young people who are from a white ethnicity, but actually you're seeing a rise in young people from ethnic minority groups, which actually might be even more rapid than the rise in young people from white backgrounds. Now, obviously, studies kind of slightly unsatisfactory in that we weren't able to get fine-grained detail on ethnicity, and you know, it's simply not good enough in future studies that, you know, we collapse everyone from a South Asian background into a single category, but that's the nature of the data that were available. So going forward, we do need more fine. But this study suggesting rates might be going up faster in people from minority ethnic groups. But that isn't the big story, I think, when we look at suicidal behaviour and ethnicity. For me, the big story is about access. So in that study, you know, it's a big study over a number of years, Oxford, Derby and Manchester. People from young people from ethnic minority groups who self-harmed came from more deprived areas than young people from white backgrounds. But it was the access to care, so they were less likely to get a psychosocial assessment. Everyone's supposed to get a psychosocial assessment after self-harm, less likely to be in receipt of mental health care, more likely just to be referred back to the GP. They were less likely to be at a similar instance of suicide. But it's this access, you know, why are young people from ethnic minority backgrounds not getting equivalent access to care? So we've talked a bit about men in midlife, we've talked about people from ethnic minority groups. This is data that came out a couple of days ago. It's about suicide by occupation, which is something else that's been in the news recently. Again, these are ONS data who are asked about suicide rates in kind of caring, in the caring professions. And for men, there were no occupations with higher suicide rates than the general population. For women, the one group that had higher rates than the general population, statistically significant higher rates, was nurses. So the rate in the population is about 5.5, 5.5. The rate in female nurses here is 7.1, so a bit higher. Some of these other occupations were a bit high, but because, you know, because of it's a statistical problem. So these increases weren't statistically significant. For female nurses, they were, and that's something we've known for a while. Again, we can kind of speculate on the reasons for that. You know, to what extent is that an occupational an exposure risk directly linked to occupation, but higher rates in female nurses, and these are it's a recent time period. Deaths registered 2016-2020, so it doesn't quite, because the deaths registered doesn't quite cover the whole of the pandemic period. So some of the data, another quick couple of things that have been published recently. One of the things that's been quite important in recent years is thinking about information sharing for people who are at risk of suicide. And this has come from bereaved relatives who, you know, I think quite rightly have felt that sometimes information hasn't been shared with them. Us as professionals have, you know, almost hidden behind this notion of confidentiality and haven't shared information when it's been appropriate to do so. So the idea behind the consensus statement is to almost have it as a kind of default that, you know, obviously we would seek the service users' consent, but, you know, saying, well, in general, when families are involved, that's a good idea. So getting that consent early on and sharing information in order to prevent suicide. So that consensus statement's been updated. I've included the links in the slide, updated in particular with regard to the new data protection legislation. And the Zero Suicide Alliance have produced this really nice kind of practical guide on consent, confidentiality and information sharing. And yeah, that's obviously within the bounds of guidance from Royal College of Nursing and GMC and others, but that's well worth a look about how we should as a default be sharing information, obviously with consent when it's appropriate to do so. Online harms, that's something that comes up all the time. Obviously, you'll be aware of the online harms white paper. The Department of Culture, Media and Support asked the Law Commission to have a look at, you know, what additional laws might be needed. So they did this review and published in July. I mean, the main recommendations were, you know, a new harm-based communication offence. So it's not about people taking offence, it's about what harm results as a result of the offence. But the big thing from the point of view of suicide and self-harm is this new offence of encouraging or assisting serious self-harm. So, you know, in some ways quite a positive development. I think Samaritans and others have rightly pointed out, well, you know, what if it's not quite serious? How do you define serious? And how does, you know, information seeking on methods, how does this fit in, and how will this be regulated? So lots of questions, but be aware that there's stuff going on in the realm of online safety. And of course, the last thing I'd like to do is thank all our wonderful staff. So I'll stop sharing at that point. And Tom, I hope you got some of that anyway.
Sorry, my computer was very slow to take me off mute there, but yeah, I got all of it, I think.
Oh, good. Good.
You weren't talking to yourself at any point.
We had a nice interruption at one point. It wasn't singing this time, but, no. But someone was having a conversation. So glad we got through that.
Yeah, absolutely. So this is time for Q&A. We please take the opportunity to ask lots of questions. We've got one already from Chris in the chat actually now, so I'll just start with that, which is I don't know if you can see the chat, but it's I don't know, Chris, perhaps I'll ask you to come on and just sort of give it a context and ask the question rather than me just read out what you said.
Yeah, sure, thanks. That was really helpful, Navneet, as ever. I don't know if this is something that you have access to or not. We've noticed that in Staffordshire, and actually I've noticed across the border as well in Shropshire, we've got what seems to be a consistent growth in suicide rates in women. And other than the fact that at this point we said we really need to look into it and try and work out what on earth's going on there, I just don't know whether the data we get, sort of standard data we get, it doesn't give us enough information there from that. I just don't know if there's anything you might have that might help us to sort of look into that, or if there's anyone else who's got a similar experience who might help shed some light.
I mean, you know, there's two lots of recent ONS data, and the links are in my slides, which will be available, that will break it down a bit more kind of fine grained. I mean, one of the groups we've been a bit concerned about recently is women in kind of midlife and what's happening there. And obviously younger people, both men and women, rates have been going up over the last few years. So but it will vary from place to place and according to kind of demographics. And I think you're right. The initial step is a bit of kind of surveillance and public health intelligence, finding out who the people are and whether it's, you know, a temporary pattern or a more sustained pattern. But yeah, I mean, no stunning insights from the data nationally, but something that needs looking at, and do have a look at the links because they'll give you the kind of detailed breakdown. The other thing is, I mean, I've not mentioned it for a while at these meetings, but there's the Public Health England fingertips tool. Now I know Public Health England entity has not is you know has morphed into other things. But I'll look up if that public health fingertips tool is still available, because that's really helpful and allows you to benchmark different areas.
It's certainly there for that, so we can so I can compare. Yeah, even down to district level, I can do that. What I haven't got is, what it doesn't do is anything like an age breakdown or something like that. So what I don't, all I know is generically, it's going up in women, if you like, and I need to look at trying to understand what we're actually looking at there.
Yeah.
Thank you, Chris and Nav. There's just a couple of responses to that discussion in the chat as well, actually, which it might be worth bringing in from Marina and Rachel. Which are about means in women, so both of them. So Marina, not different parts of the country. I think Marina's West Country. I think Rachel in West Sussex, talking about hanging as a means that's on the increase for women. Is that something that you've got any intelligence about?
That's. I mean, it's increasing, unfortunately, across the board. But yeah, in women as well. Where in some age groups, traditionally, self-poisoning used to be the most common method, but now hanging is taking over, especially in some age groups. I mean, the difficulty from a prevention point of view, I mean, we'll hear about inpatient settings later on today, but the difficulty with, something like hanging from a prevention point of view is how you prevent, it's a bit of an uncomfortable conversation in many ways, but how you prevent access to means. And our thinking there is something more population and media based. It's how you make the method less, if you like, cognitively accessible to people. But it's a huge challenge, actually, the suicide by hanging, and it's not just in the UK. It's an international problem.
Yeah, thank you for that. And then there's a couple of other questions about the real-time surveillance data. So from Sue and from Ben asking a similar question, which is about, is there any, have you looked at the data since October 2020 and 21?
We're in the process of kind of collating it, because I think what we want to do is we want to break it down a bit now, because that was just, overall numbers. And so I think it's really important, as we've already kind of been hinting at, to break it down by gender, break it down if possible by age, possibly break it down by method. So that's what we're looking at the moment. We have quite a lot of the data in. That isn't yet finalised, but we will hopefully in the coming months be putting out a report on that.
Okay, thank you. Lots coming on the chat. I'm just going to go to Keith, actually, who's put his hand up. Sorry, Keith.
Hey, Keith.
Thank you. Hi. Hello there, Nav. It's just on the hanging and the females bit, and I guess the bit I've often heard you say is, okay, it may be tricky in the sense of how we can do prevention work with that method, but actually there's a lot of stuff we can do, and one of the ones, I guess, is the self-harm bit, because many of those that have gone on to take their life may have had previous events, and therefore that need for intervention and assessment and appropriate support is one of the ways which empower us to do something. Just for you to comment, really.
No, you're absolutely right, Keith. So one of the things when we're talking about particular methods is, sometimes we're saying, well, what specifically should we do doing our hanging? And we've talked about kind of cognitive availability, but Keith's absolutely right that those general suicide prevention measures still apply. And of course, many people who die by suicide, not just by hanging, have previously hurt themselves, and self-harm is a really important, provides a really important opportunity to intervene. But all the other things that all of you guys are doing as part of your local plan. So I think that's a really important point, Keith. That sometimes we're saying, oh well, maybe that's a difficult method to prevent access to, but actually those more general kind of suicide prevention measures remain really, really important.
Thank you, Nav and Keith. I'm just going to move. Well, actually, no, I'm going to stick on this kind of, I think, maybe theme, and that's a comment from Louise Finnis about the media. And so Louise is saying that we've seen an increase in the media breaking the kind of code around reporting around suicide. So she said, are there any plans to strengthen the guidelines or if there's greater penalties? I'm not sure yeah, well, I wonder what your view
Yeah,
was.
I mean, I think the tricky thing about the media guidelines is certainly one of the things we find locally is, you know, the media professionals tend to change. So you just develop a relationship with one lot of kind of editors or media professionals, and then they change, and you've almost got to kind of keep chipping away and keep reminding people. So I don't think there are any plans to kind of strengthen the existing guidance. As you know, there's the Samaritans guidance, there's the IPCC work as well, and I think, you know, some of the kind of online harms stuff that I've talked about will feed into the general debate about how the media portray it. So in some senses it's probably not about kind of legislating, but it is about making sure, you know, certainly in your local areas, you've got a good relationship with your local media professionals, and that's continually refreshed because there'll be quite a big turnover of local journalists. So I think that's the most important thing. And, you know, as you said, the guidance is there, and it's pretty good.
Thank you for that. So many comments coming in and people sharing kind of how things are in their area. And I suppose I'm just looking down to what Katie Simpson, I'll come back up to some of the comments that I haven't mentioned, but what Katie Simpson's mentioned there about seeing actually in their area, which is Berkshire, probably an increase in female rates again. And Sue said about a spike after lockdown. I'd be interested in your take on it, Nav, I suppose, on, you know, we've talked a lot in these sessions, and you and Lewis talked a lot about, you know, that initial data that there was no increase in the suicide rates, and that we talked about again today, as always kind of cautioning us with that, because saying, well, you know, there's that data, but actually the impact of the pandemic will be longer term, and often will be other things like the, you know, the economic impact, and, you know, things like the universal benefit, the universal credit cut that happened today, was it yesterday, and these things will all have impact. I suppose when we run these learning sets and workshops, I think there are always people saying, well, we're starting to see an increase in our area, we've noticed. Appreciate that you don't have the data, you don't have the absolute data to talk about this, but where are you at with kind of thinking about at the moment, what's the you know, how are things, what's the kind of how worried are you about things?
I mean, I think am I concerned? Of course I'm concerned, and we have to remain vigilant, but one of the things we have to appreciate is the effects are going to be different, and different areas are going to see different things happening. You know, that's the nature of suicide, it's the nature of suicide rates. So I think, you know, my advice for colleagues in local areas is, you know, you need to keep an eye on things and then respond accordingly. And, you know, quite rightly, I think in some ways we've all been really focused on, look, is there a rise, is there a fall? And I think that's important, obviously, but actually even more important than that is maintaining the suicide prevention kind of focus. So some people have made the interesting point, well, you know, sometimes if you're saying rates are going down, you know, there's people in our local areas, colleagues have been telling me that, oh, they almost lose interest, you know, and so I think in a way we're absolutely right to be thinking about, well, what are the issues in our local areas, or, you know, if there is an increase, we need to be concerned about that. But actually, the focus should probably be on prevention. So I think, you know, the suicide in women is a really interesting example. So, you know, that ONS data suggesting actually there may have been a rise in women over 75, and, you know, why is that? And, you know, people saw a similar rise in relation to the SARS epidemic in the Far East, you know, 20 years ago. So what's that about? And people have been talking about disruption to helping networks, etc. So I think, you know, we've got to keep an eye on things. So all local areas, my advice to all local areas is you need to keep an eye on your local priorities, you need to keep an eye on what's happening with the local statistics. But in fact, the bigger task is maintaining the suicide prevention effort, I think.
That's really helpful at Nav, actually, I think. Marina, you've got your hand up. I had it for a little while, so apologies for the delay, but I'll just hand over to you.
Oh no, let's go. Hi Nav.
Oh yeah.
Hi Tom. I was just I went to a conference the other day. It was the Suicide Bereavement Conference, and there's quite a lot of talk about moral injury and moral trauma. And for those that aren't familiar, do take a look. But so it struck me, of course, looking at those incredibly high rates in nurses, and in short, for those listening, moral trauma and moral injury is when you've not been able to do the right thing because you weren't given the option. So we know that for many nurses, male and female, but predominantly female, working on those wards, having to decide who to ventilate, who not to ventilate. So who were they going to let die? And people working in care homes too. And I guess my not so much a question, but an instruction maybe, that trusts really need to be thinking about what interventions are put forward for nurses, for whom arguably it's possible those stats could increase. So I guess we talk about intervention when we're looking at the public, and I wonder what those interventions might look like and who might encourage those specifically for nurses who are still working on those wards. And we're not talking about burnouts, we're talking about moral injury, aren't we, and moral trauma, and they're very different.
Yeah, I think they are, and I think that if you like, the big issue is how we take care of the psychological and physical healthcare needs of all our staff in what's been a really trying time. And I think the moral injury thing is a really important aspect of that. Staff in particular settings have been put under pressures they've never been put under before. So I think all people working in NHS organisations, people working in social care organisations on the call, we've got a responsibility to look after our staff. But in fact, this issue of high suicide rates in nurses predates all of this, so it isn't necessarily to do with moral injury. And we ONS produced a report a while ago. We did a pilot study on a smaller number of nurses who'd sadly died by suicide. Rates are high, and is that a direct result of occupational pressure? Well, there's some suggestion that they might be factors in some deaths. Is it to do with access to means? Well, there's some suggestion that might be important too. So I think there is a specific issue about the care of our staff during what's been a really, really difficult time for them. But actually, there are wider issues, I think, that predate the pandemic and are going to be important going forward. But I think you're right. For me, the big message is, well, what are organisations doing to look after their staff? That's got to be the issue.
Yeah, no, thanks, Nav. I guess it was just literally that. Absolutely. I mean, I friends working on the front line in social work, and everybody faced such difficult, roles during COVID. But I guess literally when we're looking at a matter of life and death, I'm really struck by, nurses, doctors, and care home staff. But anyway, yeah, thank you for your feedback.
Thanks, Marina. Thanks, Navi. I was going to ask about the figures around the suicide in nurses, which I won't ask now, because my question was going to be about whether you'd seen anything about whether there was any difference between those rates pre-COVID or post-COVID. It might be too early to even be able to answer that question.
I mean, they didn't look at pre and post-COVID because those data go up to 2020 registrations. So
so that would be pre.
So it's mostly pre-pandemic, although there's a bit and that I think will be difficult to look at. But they did in that report, so please kind of click on it. It's a data report. They did look at rates over time, over 2 5-year periods, and didn't see a particular difference.
Yeah. Okay. Thank you. That's really helpful. I also wanted to ask a question, Nav, about men and your recent study around that, which I thought was, kind of challenged to receive wisdom a little bit, as you said in your presentation about men, which is that, and a lot of work we've seen from people on this programme has been about trying to go where men are, I suppose, and reach and to help people to get into services. But I think perhaps what that's sort of showing is, well, that's not, I mean, that's not the only part of the issue. The other part is that services are kind of acceptable and helpful to men. And I wondered if you had any sort of further advice around that.
It's really important to say that I think, you know, all that access work that people have done has been really important, really valuable. And it's another example of where, if you like, this QI program, this quality improvement program, has been evidence generating, because we don't know a lot about how to prevent suicide, how to reach men in midlife. So all of that, I think, has been really helpful. But I think you're right that that's only kind of part of the story. So go to where men are. But then when men come to you, if you're in a social care or healthcare service, make sure what you provide kind of engages them and is fit for purpose. Now, I'm getting asked quite a lot, well, what does that look like, Nav? And the research, there isn't a whole lot of research evidence to guide us. And again, this is an opportunity to be thinking about how local services are shaped. And, you know, if people are doing that as part of this this program, you know, recording it and sharing the learning. I mean, one of the really striking figures from that Men in Midlife report, again, you know, please do click on the link, is of the men who died, 44% were prescribed an antidepressant, but only 5% were in receipt of talking treatment. So, you know, it may be that that's appropriate antidepressant prescribing, people are depressed, but, you know, it does seem quite a low level of access to psychological therapy. So, you know, is that access, is that referral, is that acceptability? I mean, we do need to do a bit of work around that. But I know, you know, some colleagues around the country are doing some work about, you know, what men want from services and how they best kind of provide that. I think that's going to be a really important area going forward.
Yeah. Do you know how that compares, that 5% of people in receipt of psychological therapies, how that compares with women who die by suicide?
It's higher. I haven't got the figure. I think it's higher. We haven't done the studies directly, but it'll be, I mean, it's not going to be vastly higher, but because it'll still, I think, be around 1 in 10, but it's certainly higher than 5%.
Yeah. I mean, it does seem very low. I was curious as to what, you know,
and Marina,
not psychological therapists available
about you know, the Hope project that they were running in Bristol. I'm sure she'd be happy to talk to colleagues about that.
Yeah, absolutely. The other thing I was going to just return to from the chat was something that Louise Patmore said, well, probably about 15 minutes ago, which is about the measurement, really. So do we know what inputs? So much work been happening as part of everyone's suicide prevention work over the last few years. You know, lots of it in this program that we've heard over the last 3.5 years, and of course lots of things happening not in this program as well. And Louise has listed a lot of interventions that are happening in lots of places, and do we know what the impact of those are? And I think it's a really difficult question. We kind of have talked occasionally about measurement in the program, and it's really hard to measure the impact of these sorts of interventions, because
it is and I think someone made the point in the chat, because it's almost about, well, what would the rates have been doing if we hadn't intervened? So I think someone in the chat made the point about, well, is part of this the fact that we had all these mitigation, is the part of the reason for no rise is because we're doing all this suicide prevention work, and of course that's a really potentially important factor, that, you know, there's all this suicide prevention work going on, you know, that perhaps is part of the reason that post-pandemic we didn't see a rise. So it is difficult. I mean, we will be looking at suicide rates kind of going forward and longer term, so we'll be able to get a kind of indication. But for our advice, and again, for those of you newer to the program, there's a data dictionary on the program website which shows you some of the things you want to measure. So the outcomes are really important. So it's important to measure suicide, self-harm, but actually the process measures are really important as well. So things like, you know, if you're looking at a self-harm service, you know, is there one there? How many people are accessing it? You know, what are some of the kind of software outcomes? What are some of the process outcomes that we know downstream will be related to suicide. So in some senses, I mean, the outcomes are, of course, they're absolutely important, but this is about providing the best kind of care, the best kind of environments we possibly can, and then suicide rates, I think, coming down will follow from that. So I think we'll be looking at outcome data going forward, but actually that's only part of the story. So you guys measuring what you're doing and having a good record of what you're doing constantly, Tom and colleagues talk about the QI methodology, adapting things if they don't quite work, reintroducing, remeasuring, I think can be really powerful. But I agree. I mean, it's been a real privilege being involved in this. We're talking about suicide prevention like we never did before.
That's brilliant. Thank you. And Christie's just put a link to the data dictionary in the chat, which is super helpful as well. So people who are newer to the program or haven't seen that, or anyone who wants can remind themselves of it, because I think it's really helpful. And it's that kind of is based on a bit of a theory that if you do these are things we think will help to prevent suicide. Let's measure the impact of them, and we think that all of those things together will have an impact on suicide rates. But we know also that suicide rates are impacted by things completely out of our control. In lots, we just had an unprecedented pandemic in the modern era. Like I say, things like government decisions about benefits or things that affect employment. These things are also impact part of the picture as well, aren't they? But you'd like to feel like this work has made a difference. It feels like there's so much more momentum around it now that it's.
I think everyone can be confident that I'm sure it's made. I'm sure it's made a difference. People are talking about suicide in a way they haven't been talking about. In my 25 years working in suicide prevention, there's an energy and enthusiasm for from the people who are on the call about preventing suicide, and that will have had an impact, even if in the end statistically we find it difficult to show that impact, because suicide rates do naturally go up and down. So I think we can all be reassured that I think people are doing a fantastic job, really.
Yeah, thank you. I'm just going to go to Louise. We were just talking about an issue that you raised without asking to speak, but you put your hand up now, so I'll go to Louise.
Yeah, it's just that there's been so many things. I'm mental health participation program lead in Sussex, but there's been all sorts of things from Masons getting together and calling each other every day. When the pandemic started, there were men in sheds, veterans, breakfast clubs. The people were galvanizing around the suicide prevention conversation. And there's really good examples from many places that, and in Sussex we did Ben Brown's on the call, he was involved in this, an innovations fund where we gave small bits of money to small organisations, and we had two. Are you still able? Yeah, you're still blinking. I can still hear you, so I thought you got frozen. Where we're able to have a kind of a bit of a what's it called? An audit of the efficacy of it, and the Citizens Advice Bureau debt advice meant that I think 37 people were involved in that. None of them returned to acute services, for example, and so they're really strong sort of outcomes from small. That I think will be really helpful to get this prevention impact assessment stuff, because I think it's really important to understand that if we took all that stuff away, yes, I think situation would be far worse.
Yeah, and I think the other two really important points there is, in particular, one is around if you like, the community kind of cohesion around time early on in the pandemic. But the other really important thing that I mean, in a way, I want to mention everything every time, but then it does become slightly repetitive. But you raising the really kind of central importance of colleagues in the voluntary and third sector, again, who might be partly responsible for the fact that suicide rates haven't gone up. People have been accessing mental health services less. The question is where they've been going, and certainly some third sector and voluntary sector colleagues are saying, well, we've been busier than ever. So, in your plans, in your strategies going forward, involving third sector colleagues, I think is absolutely fantastic.
Right, thank you so much, Nav, and everyone else as well. That was a really interesting and lively discussion as ever. Nav, thank you for a brilliant presentation.